Paramartha Bhattacharya for the last.
Yeah. Thank you, sir.
Topic is cardiometabolic care with linagliptin.
Thank you, sir. 6 balls left, 2 runs to go. So, what is the relevance of linagliptin in cardiology clinics? Well, this is, of course, a sponsored topic, so I had to say something. But I tried to find out a case in which we will really start linagliptin. This is a patient, yes, this is a 67-year-old patient, known diabetic for 20 years and have a stable coronary artery disease. He has some amount of chest pain, maybe when he's walking for more than 3 or 4 kilometers. And he sometimes takes sublingual sorbitrate. He is on, of course, aspirin and atorvastatin and other medications, and has a normal kidney function test. So this is the echo. How can I? This is the echo, and in the plaques view, you see we don't have significant RWMA, or the EF seems to be normal, and we don't have any MR also. And this is the plaques view, the short axis view, in which the RWMA is not very significant. And if you see the GLS done in this patient, you have some amount of compromise, though the ejection fraction was normal. So this was the GLS like, and this is another way of seeing it in the G machine that I use. And they said that this blue part is the ischemic myocardium and the white part is the non-ischemic myocardium, which shows that there is more or less ischemia in the anterior, anteroseptal, inferior, and the posterior area. So a decade of, and this patient, if we get in our clinic and if we are cardiodiabetologists, we will jump into giving this patient a SGLT2 inhibitor, so much as our experience and so much as we are taught nowadays. So let's look at the other side. Why not the DPP4 inhibitors, and why did we try to put the DPP4 inhibitors in the posterior bench? So linagliptin was another DPP inhibitor which was launched in India in 2012. In 2013, the Carmelina trial started. Linagliptin showed a lower ring of albuminuria. The safety in elderly was added on insulin, even on insulin. Safety regardless of the hepatic dysfunction was found in 2017. And the US real-world study was over 150,000 patients. 23% reduction in the risk of composite CV outcome was shown with respect to sulfonylureas. The Korean registry was over 5 lakh patients, and 26% relative reduction in hospitalization for heart failure with linagliptin and compared to sulfonylureas was shown. In 2018, the established CV renal outcome was shown, and similar efficacy of linagliptin to that of glimepiride in lowering the risk of hypoglycemia was shown. The safety in elderly patients was shown across all EGFR in Asian population as an add-on on insulin. That was in 2020. In 2021, the safety in hospitalized patients was shown, and why not, we are taking it forward to 2022. A decade of simplicity with linagliptin was there. Well, our prime concern when we are using an oral anti-hypoglycemic agent is hypoglycemia, and is associated with MACE and all-cause mortality. We have shown through these trials of ACCORD, ADVANCE, EXAMINE, ORIGIN, LEADER, and EVOTE, and why linagliptin should not be relevant. So with linagliptin, more patients achieved glycated control levels without hypoglycemia event or weight gain compared to glimepiride. 76% on glimepiride per metformin, and 76% on linagliptin plus metformin was seen, and it was shown that a proportion of patients achieving the glycated target of less than 7% after 2 years were more with linagliptin, and the proportion of certain achieving glycated of less than 7 years after 2 years without weight gain was more in case of linagliptin. So hypoglycemia and weight gain are the clinical challenges we know. The hypoglycemia is caused by this lightheadedness, blurring of vision, sweating, trembling, palpitations, fast anxiety, confusion, etc., and increases hospitalization and increases the cost, reduces the quality of life, and causes a suboptimal outcome. Most important is once your patient is getting hypoglycemia and getting admitted to the hospital, the whole system of treatment changes on the patients, and what happens is the day-to-day variation of glucose that brings up. And nowadays it has been shown that day-to-day variation of glucose is more important in causing the cardiovascular mortality of the patients rather than your long-term control. So when choosing a glucose-lowering medications for overweight or obese patients in type 2 diabetes, consider their effect on weight, and whenever possible, minimize the medication that causes weight gain. That should be the recommendation. And glycemic efficacy of linagliptin as compared to glimepiride with lower risk of hypoglycemia and weight gain are this. Glycemic efficacy was lowering the risk of hypoglycemia and linagliptin with linagliptin was shown in that Carolina trial, which was not very incompetent as respect to glimepiride, and 1.5 kg relative weight loss was seen with linagliptin than with glimepiride. So extensive CVOT data is also available for linagliptin. By now, the Carmelina and the Carolina trials demonstrated that the long-term safety. In Carolina trial, the median diabetes duration was 6.3 years, has pre-existing ASCVD 42%, 37% has more than 2 CV risks, 40% had type 2 diabetes for less than 5 years. We had an active comparator on the other side on metformin, on insulin, and treatment-naive patients. Here in Carmelina, the mean duration was more than 15 years, 74% had active kidney disease, 57% had established CV disease, and 33% had established CV disease and prevalent kidney disease as well. And it was compared with the placebo. And what happened was this: the p-value was significant in both the Carolina and the Carmelina arms with respect to three-phase MACE, hospitalization due to heart failure or CV death, and all-cause mortality. The significance was achieved. So CV and renal outcome in DPP-4 patients, linagliptin is safe across all the renal output trials. In Severtimi, it was Saxa. In TICOS, it was Sita, Carmelina, Lina, and of course, the hazard ratio was all between 0.8 to 1. And linagliptin stood its time stood the test of time in Carmelina trial. The subgroup analysis of Carmelina was in North American subgroups, there was 35% relative reduction. In Asian subgroup, it was 53%. And patient not using insulin at baseline was 38%. Carmelina is the only DPP-4 CVOT to have a hard kidney outcome as pre-specified and statistically powered endpoint. DPP-4 inhibitors dose reduction was required in renal impairment with the exception of linagliptin, where 5 mg dose once a day is allowed and without any dose reduction. So linagliptin is a DPP-4 inhibitor with the unique and comprehensive CV outcome program. So the number of CV outcome was 2. The demonstrated CV safety was there. The demonstrated renal safety was there. And the hazard ratio was important. So linagliptin is appropriate in a broad range of diabetic patients whenever we decide to prescribe a DPP-4 inhibitor, and is in once a day dose, independent of any dose reduction, and of the kidney function being abnormal, the liver function is not affected, The CV risk is better, age, BMI, background, DM therapy associated with any other treatment, including insulin. The duration of the disease and ethnicity all favor the use of linagliptin. So why not, with a 10 years of simplicity, why not linagliptin? Thank you for your pleasant listening. And if we have any questions, maybe.
Thank you, Dr. Paramartha, for this brief but very lucid and precise presentation. The molecule linagliptin, the magic point is that you don't have to really bother about the background of the patient.
Yes.
I mean, cardiac function, renal function, hepatic function, irrespective of everything, you can use this molecule in any diabetic who needs it. It is definitely cardiovascular and renal safe, and maybe there is some semblance of protection in the real-world studies. And with SGLT2, it forms a perfect combination with empagliflozin. So these are the points that's to be highlighted. So we have been using it in patients with very compromised renal function and found it to be absolutely safe. And lack of hypoglycemia is another point to be highlighted, but that's generally a class effect. So anyone with any further comments on the topic? Or Dr. would you like to say something?
No, I have nothing more to say. We are running very late, and since there are no hand has been raised, I would close the session here and we would straight away go to valedictory from here.